really a pleasure to be here, and I've always thought that Mercy will be the first female president, so forget it, Hillary. Anyway, the title of my talk today is Mental Health Risks of Abortion, looking at the evidence and the contemporary state policies, and I just updated this a few weeks ago, so it's all very current. 4 objectives, essentially. We're going to look at challenges to acquiring and disseminating scientific data on abortion and mental health. We're going to review the abortion and mental health literature, focusing on studies published in the last 5 years. Consideration of what women should be told regarding this literature in order to foster informed decision-making. Review of state laws mandating dissemination of information on the mental health risks of abortion. So it's a lot to cover. Hopefully I get to it all, but we'll skip over some if we have to. I did make handouts of all of my slides, and for once they look nice. I think I'm notorious for having kind of crummy looking handouts. The university does them for me, and we just got a brand new colored printer, and they look absolutely great. And we flew in on Spirit this morning, and they lost our bags, so they're in a bag, supposedly arriving here at 9 o'clock tonight. So I'll put them out in the hall at some point, or I can email them to you. But it's really disappointing because for once they're nice, and I have some other data that I've made copies of, so I'll put all of that out there. So when we look at academic jobs in the United States, it's interesting to kind of the state of academia in terms of tenure-track positions. There's really an overabundance of PhDs, and only about 15% secure jobs. They don't tell you that when you're in training. We're actually recruiting right now. We got 60 applications for one job at Bowling Green. So in this climate, few aspiring faculty will take on a research agenda like abortion and mental health. It's frowned upon by the mainstream. And once in a job, studying the potential adverse effects of abortion makes tenure and promotion much less likely in a liberal academic environment. And you may be familiar with the case of Mike Adams. He was at the University of North Carolina, Wilmington. In 2006, Dr. Adams, an associate professor, applied for promotion to full professor. He had published more peer-reviewed articles than most of his colleagues, and he had won 3 teaching awards. Adams was denied promotion and wasn't given an explanation. He believed it was due to his Christian faith and because he was a popular conservative pro-life author at townhall.com. Finally, after 8 years of litigation, a jury in the U.S. District Court agreed. So what are they funding with our tax dollars? When we think about the research that is out there, it seems a little bit out of order here. Sorry. This couple slides got a little bit out of order here. We'll just go with it. It's very difficult to secure funding through the National Institutes of Health or the National Institute of Science on the topic of abortion, particularly abortion and mental health. And I just thought it was funny to look at some of the projects that are getting our tax dollars. Key to Happy Marriage, $325,000. The finding here was that the happiest marriages were the ones in which the wives were able to calm down quickly during conflict. Massage and rabbits, $386,000. According to the principal investigator, this is a study applying massage to rabbits to try to figure out what's the best massage duration. Here's another good one, $2.4 million to develop origami condoms designed with Japanese folding paper in mind. $939,000 to find out that male fruit flies prefer to romance younger females because the girl flies' hormone levels drop over time. Despite the limited NIH funding, the pro-choice researchers seem to have access to almost unlimited funds through other organizations. For example, Warren Buffett donated $1.2 billion to pro-choice organizations in 2013, and the Susan Thomas Buffett Foundation, which was named after his late wife, has provided high-dollar grants to pro-choice researchers, including Trine Mulk Olson and Julia Steinberg, among many others. And the Buffett Foundation does not accept unsolicited requests, They prefer instead to seek out worthy, quote unquote, recipients on their own. In 2013, over $25 million in grants was awarded to individuals. So how do we determine informed consent for abortion based on contemporary facts? Doctors have a continuing duty to be familiar with up-to-date information on risks of treatments or procedures to correctly inform patients. And the standard of disclosure has shifted to what a reasonable or prudent patient might want to know about a procedure from what a reasonable doctor might disclose. So what are the key elements when we think about informed consent relative to abortion? We need to determine competency to make the decision, educate the patient about the procedure with information presented in understandable terms, provide gestational age and fetal development information, provide accurate and sufficient information including the physical and psychological health risks of abortion and alternatives, offer an opportunity to ask questions in a private, individualized context, provide sufficient time for counseling and decision making, make sure the decision is voluntary and free from coercion or pressure. And there is a new era in research on abortion and mental health, so in terms of disclosing appropriate information, there's a very large literature now that should be drawn upon, particularly in the last couple decades, the last 10 years. And there is an emerging core of highly respected and highly ethical researchers determined to address the topic and actively challenge the status quo. Sometimes they're not personally pro-life. For example, Dr. David Ferguson here from New Zealand wrote in his 2013 article, quote, "The growing evidence suggesting that abortion does not have therapeutic benefits cannot be ignored indefinitely, and it's unacceptable for clinicians to authorize large numbers of abortions on grounds for which there's currently no scientific evidence." He describes himself as a pro-choice individual, a rational atheist, and yet he sees that in the science there's corruption in terms of what's published and what information is made available to the public. He also helped me out personally. He was one of my external reviewers for tenure at Bowling Green State University, and then also for promotion to full professor. So we have a lot of dialogue back and forth. I respect him a lot. He initially went into his longitudinal study expecting that he wouldn't find any associations between abortion history and various mental health problems, and he found very strong effects, stronger than what we were finding, and then he struggled to get the data published. Many of his papers had to be submitted multiple times, and this is a man who has like 300 peer-reviewed articles and has never had any issues publishing, so he came directly in contact with the major biases and struggles there. So there are decent, good researchers out there. And over the last 2 decades, hundreds of studies documenting abortion as a risk factor for mental health problems have been published in premier psychology and medical journals throughout the world. Some of the countries that are now producing good research include Australia, Belgium, Canada, China, Japan, New Zealand, Norway, Pakistan, just found one from Pakistan the other day, Sweden, South Africa, among others. So what psychological information should be shared with women prior to abortion? There's kind of 2 sets of the literature, 2 aspects of the literature that really need to be shared. There's data on personal and situational risk factors for post-abortion mental health problems. So women need to know, are they in a high-risk group for having an adverse reaction? And then the data on mental health outcomes that occur more often among women who abort compared to those who do not. So looking at the risk factor data, first of all, if the pregnant woman is pressured or coerced by others to abort, strong risk factor. If she's religious or views an abortion to be in conflict with her personal values. If the pregnant woman is ambivalent about the abortion or has a high degree of decisional distress. If she's committed to the pregnancy or she preferred to carry the child to term. Belief that abortion terminates the life of a human being, and or the experience of bonding to her child. There's some great studies out of Australia that were published about 10 years ago, and in one of the studies, the researchers demonstrated that women fully intending to abort, in early abortions, like under 3 months, and they still experienced strong bonding behaviors too, even though they had no intention to carry to term. So about 50% of the sample reported bonding type behaviors and emotions. The pregnant woman is an adolescent or a young adult. She has pre-existing mental health or psychiatric problems. Character traits suggesting emotional immaturity, instability, or difficulties coping are present. She's in a conflicted, unsupportive, or abusive relationship with the father of the child. The pregnant woman is involved in negative relationships with others. And then a few studies that have shown that if the woman reports indicators of poor quality abortion care, feeling that she was misinformed or had inadequate counseling, negative perception of the staff, etc. So despite the availability of strong research documenting risk factors and professional awareness, abortion providers rarely, if ever, routinely screen for risk factors and counsel women at risk. And there's an abundant literature comprised of hundreds of methodologically sophisticated studies now that indicate abortion significantly increases risk for the following mental health problems: depression, anxiety, substance abuse, and suicidal ideation and behavior. And there are other outcomes as well that have been examined, like sleep disturbances, eating disorders, but these are the 4 that have the most data behind them. Abortion is further associated with a higher risk of negative psychological outcomes compared to unintended pregnancy carried to term. And the strongest studies published between 1995 and 2009 are synthesized in my meta-analysis that was published in the British Journal of Psychiatry in 2011. I'm not going to talk about it much, I've talked about it before plenty. But the main findings here were that women who had an abortion experienced an 81% higher risk for mental health problems of various forms compared to women who have not had an abortion. And significant increased risks were observed for all the following outcomes: alcohol abuse or use, 110% increased risk; marijuana usage, 230% increased risk. Byron had one of his slides from one of our older studies from 2002 in the American Journal of Obstetrics and Gynecology. I think who knows how we got that study in there. It was like a miracle. But I think we had like a 10 times increased risk of marijuana usage, and that was women who were actively it was right at the time that the data was secured was right at the birth of a child, a second child when the prior pregnancy had been aborted. So this marijuana is an interesting link, and it's not there aren't that many studies that have looked at marijuana. Anxiety, 34% increased risk, depression was 37%, and then suicidal behavior is 155%. And within the meta-analysis, I did separate analyses and looked specifically at unintended pregnancy carried to term compared to abortion. And when looking at those women, or the studies that had that variable, we found that there was an increased risk of 55%. So socio-demographically, women who have unintended or unplanned pregnancies, they are likely to be more similar to women who choose to abort compared to like a married woman who is having a child who is planned. And so that data is a little more meaningful. And meta-analysis yields the highest quality of scientific evidence. So that meta-analysis, we're getting some mileage out of it in terms of state laws and things. Looking at some recently published studies, I had a student pull a bunch of, she probably pulled about 80 articles recently, and I went through them to find those that were most relevant to my talk today. So there was a study published in Belgium that looked at counseling from the woman's point of view. They analyzed data from 971 women requesting an abortion at 5 different clinics. The multidisciplinary care required by law thought this was interesting, embodies a client-centered, non-directed, non-judgmental counseling session with a social worker and a medical doctor. We don't get that over here. The general objective was to explore the value of mandatory pre-abortion counseling, which is individualized, but always supposed to address the procedure, decision-making, and future contraceptive options. And so here's some of the results in terms of, so this data indicates that a significant percentage of women really did want to have that counseling and have their concerns addressed. Some of the conclusions by these researchers: the emotional and cognitive state of abortion-seeking women can be described as ambivalent, since they feel both negative and quite resolute about the decision to terminate their pregnancy. The 971 women in our sample highly appreciated the counseling sessions, although they initially felt a certain restraint. And then a study from the Netherlands. They investigated associations between pre-abortion psychiatric history and decision difficulty among 325 women recruited from 8 abortion clinics. Women were 18 to 46 years old and up to 24 weeks pregnant when they received an abortion. And then the results based on history of a mental disorder. You can see even the women who did not have a history had fairly high percentages of doubt about the decision, feelings of pressure, and feeling great burden. And then the numbers for those with a prior psych history had very high numbers here. A study from Sweden, published in 2013. The purpose was to assess the prevalence of post-traumatic stress disorder and also post-traumatic stress symptoms among women requesting an induced abortion before 12 weeks. It was a multi-center study of 1,514 women from clinics at 6 different public hospitals. The results indicated that nearly half reported prior traumatic experiences. 4% had full-blown PTSD, 23% experienced PTSD, post-traumatic stress type symptoms. There were a very high percentage of women who presented with PTSD and PTSS, who were comorbid on depression and general anxiety as well. The authors concluded women who seek abortions who have had trauma experience in the past and or have had symptoms of mental distress need more consideration and alertness from the medical personnel when they're counseled for termination. And then an Australian study, this published in 2014, when compared to those who were never pregnant after instituting controls for parent socioeconomic context and early teen psychosocial adjustment, women who aborted had significantly higher rates of substance dependence. Nicotine was 4.5 times greater, 26% of the sample afflicted. Alcohol dependence, 2.7 times higher, 20% afflicted. And then the marijuana, again, 1.7 times higher and 9% afflicted. Then this study from Pakistan. The purpose was to evaluate physical and psychological morbidity of induced abortion in a randomly selected sample of the general population. So there were only 61 in the sample, but they did a nice job selecting them. 73.8% of the women reported an average of 2.24 post-abortion mental health complications. The most frequently endorsed complications included irritability, depression, change in libido, amnesia, fear, and negative attitudes toward children. Their conclusion, lack of deep awareness of the consequences contributes to deteriorating future reproductive and mental health. Counseling services for their health risks, as well as about the human perspective on this issue, needs to be initiated for better management of their reproductive health and rights. And then this Curley study that involved a sample that was college students from the US and Canada, 151 women from 3 different universities, looking at psychological outcomes. There were 3 basic comparison groups. Women who preferred psychological services after their abortion reported they would like some help, women who did not desire services after the abortion, and then a control group of women who had not had an abortion. The students were recruited from classified advertisements, bulletin boards, newspaper ads, and so forth. The length of time since the abortion ranged from 1 month to 10 years. The average was 3 years. Ages ranged from 18 to 35. Average was 22. After controlling for coexisting mental health, depression, and situational anxiety were found to be significantly higher in the treatment preferring group compared to the other abortion group and the control group. All the women who had abortions reported some PTSD symptoms, all of them, and grief lasting an average of 3 years. However, the average woman in the preferred services group experienced heightened psychological trauma, indicating partial or full-blown PTSD. Persistent distress was reported by 50% of the women who had abortions. Post-abortion suicidal ideation was evidenced in nearly 32% of the preferred service group, compared to 14.6% of the women who did not voice an interest in services. And then their conclusions: healthcare providers have an ethical and professional obligation to develop and offer interventions that address the psychological aftermath of abortion for those women who want such services. Changes in clinical practice need to include screening, monitoring, and preventing psychological distress after abortion, especially for those who might be vulnerable. Women need to be followed up for the emergence of adverse outcomes after abortion that may occur long after the abortion. They also concluded young women who seek help for distress after abortion are fast becoming a new underserved population within healthcare, primarily because they have been marginalized by the politics surrounding abortion and thus remain untreated. Future research needs to focus on developing interventions, and their development should be a research priority. So what is the typical nature of pre-abortion services in the U.S. today? It's not individualized to the woman's unique situation, and there's infrequent evaluation of pre-abortion psychological functioning, and typically no assessment of predisposing risk factors for psychological problems, usually no assessment of pregnancy context or screening for sexual assault, often misinformation by uneducated, poorly trained, non-medical staff regarding fetal development, alternatives to abortion and risks, typically under 10 minutes, and no pre-procedure meetings with the abortionists. And what exactly are women being told then at U.S. clinics? Well, from the Planned Parenthood quote-unquote fact sheet, they're told the truth remains that most substantive studies in the last 30 years have found abortion to be a relatively benign procedure in terms of emotional effect, except when pre-abortion emotional problems exist or when a wanted pregnancy is terminated, such as after diagnostic genetic testing. And they gave me a little press. I was, of course, this wasn't all they said, but this is all I'm paying attention to. It said, so basically said, Priscilla Coleman published a meta-analysis of the research about the emotional effects of abortion that was published between 1995 and 2009. She drew a different conclusion from the literature than the one drawn by the Academy of Medical Royal Colleges. The results revealed a moderate to highly increased risk of mental health problems after abortion. So at least women will see that, They could have left it out. Insufficient information and inappropriate counseling, often by non-professionals, is likely to lead to decisions to abort that are inconsistent with women's value systems, initiate negative psychological reactions, lead to a lifetime of suffering, or even factor into a premature death. Women are not given sufficient time to make a comfortable decision, and they rarely have opportunity to ask questions in a private, individualized context. In the words of one abortion doctor, Warren Hearn, told the New York Times, as a society, I think we've been in denial about the risks of abortion, both because of ideology and because of economics. So what do U.S. women have to say about the quality of counseling actually received? For several years now, I've been conducting a study on abortion-related experiences online, and several of the items, it's close to 1,000 women now in the sample, and there are several items on women's experiences related to pre-abortion counseling. Here are just some of the items that are relevant. The counseling received at the abortion facility was brief. 85% agreed with that. The counselors at the abortion facility did not ask about any pressure I may have felt to abort. 79% agreed. The counselors at the abortion facility seemed cold and uninterested in me. 58% agreed. And I'll just kind of skip through these because I think I'm down to 5 minutes here. So, just a few of the women's actual statements. We had both open-ended questions and more of the closed-ended, Likert-type responses. But one woman said the clinic personnel were very careful to never say the word abortion or offer any options. They could see I was young and scared and alone, and they just said, we can take care of this for you. Lots of women do this, and it's fine. There are no repercussions. It's very simple. And all of these, this is in the handouts that will be available tonight. One woman did say, I needed to be supported in my freedom to choose to remain pregnant, to be cared for as the mother I already was, and defended and protected from his coercion. So there is this rapidly accumulating literature on the negative effects of abortion, and it's rarely made available to practitioners and to women considering abortion, as professional organizations, including the APA and the AMA, along with the liberal press, spend incredible amounts of energy to hide the now scientifically verified proofs. So I'm going to skip over this part and just get to I want to just talk about how the data is actually impacting policy. So despite the concerted efforts of the media to support educating the public on the scientifically verified truths about abortion, the information is now making its way into the courts. 22 states have laws requiring healthcare providers to tell patients about the emotional or psychological consequences of having an abortion. And this wouldn't be possible without the data that's out there and the literature that's developing. In 9 of these states, only negative consequences are addressed, and in the remaining 13, a range of potential emotional and psychological reactions are addressed. In Michigan, for example, women are told as a result of an abortion, some women may experience depression, feelings of guilt, sleep disturbance, loss of interest in work or sex or anger. And so there are several states. Looking also at the counseling laws, 30 of the states require information be given to a woman. 27 of the states require women to wait a specified amount of time between the counseling and the abortion procedure. 13 states require that counseling be provided in person and that the counseling take place before the waiting period. 14 states require women to be informed that they cannot be coerced into obtaining an abortion, and 29 states require disclosure on health risks. And then there are the parent involvement laws. 38 states require parental involvement in a minor's decision to have an abortion. So there are several different laws. Many states have laws related to parental involvement. More generally, since 2011, the states have instituted more than 280 restrictions on abortion. 57 of them occurred in 2015. With so much legal work, there are enormous demands for credentialed experts to testify and incorporate the scientific research into their opinions. Unfortunately, there's a shortage of individuals who have the background, motivation, and skills to serve in this capacity. My conclusion here, more and more researchers throughout the world are tackling this topic of abortion and mental health and challenging the stance of politically driven professional organizations. Efforts to hide or shrug off women's post-abortion suffering are appearing insensitive and immoral to a larger segment of the population. The painful experiences of hundreds of women who have aborted are finally being acknowledged and addressed with women-focused services and appropriate legislation. There is hope that tomorrow will bring a world where the choice to abort is unimaginable in a society that condemns violence and responds knowledgeably and compassionately to the needs of all women and their children. Thank you.